Hello, this is Dr. Thomas again. Good morning, good afternoon, and good evening, depending upon wherever you are. Today I'm going to be discussing another interesting case. Please visit my YouTube channel, like, share, and subscribe. This type of content is time consuming to make. Let's jump right in. Disclaimer. We have a 70-year-old female brought to the emergency room by her family due to decreased consciousness over the past 2 days. She has been progressively lethargic, confused, and has not eaten or taken her medications for the past 3 days. The family reports that she has been experiencing increasing fatigue, cold intolerance, and weight gain over the last few months. Medical and relevant surgical history. She was diagnosed with hypothyroidism 15 years ago on levothyroxine, but with poor compliance. Has a history of hypertension, diagnosed 10 years ago, managed with lisinopril and hydrochlorothiazide. Chronic congestive heart failure, diagnosed 5 years ago, currently New York Heart Association Class 2 on furosemide and carvedilol. No history of previous surgeries. Had a recent upper respiratory tract infection 2 weeks ago, treated with over-the-counter medications. Physical examination findings. On general examination, patient is obtunded, hypothermic, and in obvious distress. Vital signs showed a temperature of 95.2, heart rate of 48, blood pressure of 90/60, respiratory rate of 10, oxygen saturation of 88% on room air. Skin is cool, dry, and pale with non-pitting edema of the face and extremities. Examination of the head, eyes, ear, nose, and throat showed periorbital puffiness, dry coarse hair, and eyebrows thinning. Neck examination showed no goiter, neck veins are flat. Cardiovascular system examination showed that patient is bradycardic with faint heart sounds, no significant murmurs. Chest examination showed diminished breath sounds bilaterally at the bases. Examination of the abdomen showed soft, non-tender abdomen with diminished bowel sounds. Central nervous system examination showed depressed mental status, Glasgow Coma Scale of 8, and delayed deep tendon reflexes. These are the relevant investigations. Complete blood count showed WBC count of 6,500, hemoglobin of 10.2, platelet count of 180,000. Basic metabolic panel showed a sodium of 128, potassium of 4.5, chloride of 92, bicarbonate of 28, blood urea nitrogen of 32, creatinine of 1.6, glucose of 58. Liver function test showed an ALT of 20, AST of 30, bilirubin of 1.2. TSH is 75, markedly elevated, free T4 of 0.2. Arterial blood gases showed pH of 7.28, PCO2 of 50, PaO2 of 60, bicarb of 24. Serum cortisol level at the time of patient's presentation was 12 microgram per deciliter. EKG showed sinus bradycardia, low voltage QRS complexes. These are the imaging study results. Chest X-ray showed mild cardiomegaly and bilateral pleural effusions. CT of the brain showed no acute intracranial pathology. These are the important differential diagnoses. At the top of the list is mixed edema coma. Other diagnoses include hypothermia, adrenal insufficiency, sepsis, and cardiac tamponade. Final diagnosis is mixed edema coma, diagnosed based on clinical presentation of altered mental status, hypothermia, bradycardia, hypotension, and laboratory findings of severe hypothyroidism evidenced by elevated TSH and low free T4. Here is the management plan. Immediate management includes management of airway and breathing, intubation and mechanical ventilation due to respiratory depression and hypoxia in this case. Circulatory support includes IV fluids to support blood pressure and correct electrolyte imbalances, vasopressors if hypotension persists despite fluid resuscitation, thyroid hormone replacement, usually combined therapy with levothyroxine and liothyronine rather than levothyroxine alone is recommended. IV levothyroxine, loading dose of 200 to 400 microgram followed by daily dose of 50 to 100 micrograms. IV liothyronine, also called T3, can be considered in severe cases, starting with 5 to 20 micrograms followed by 2.5 to 10 micrograms every 8 hours. Patient needs to be in an ICU setting. Patient needs passive rewarming with blankets, IV glucose for hypoglycemia, and corticosteroids like hydrocortisone 100 mg IV every 8 hours until the possibility of coexisting adrenal insufficiency has been excluded. The patient must be treated with glucocorticoids in stress doses. Monitoring and follow-up, continuous cardiac monitoring, serial measurements of vital signs, thyroid function tests and electrolytes, monitor urine output and renal function. Adjustment of thyroid hormone dosage is based on clinical response and repeat thyroid function tests. Treat underlying infections with empiric broad spectrum antibiotics until infection is ruled out. These are the important clinical pearls. You should exercise high index of suspicion. Mixed edema coma should be suspected in elderly patients with non-hypothyroidism presenting with altered mental status, hypothermia, and bradycardia. Precipitating factors include infections, cold exposure, medications like sedatives, and poor compliance with thyroid hormone replacement therapy are common triggers. Aggressive management includes early recognition and aggressive treatment with thyroid hormone replacement, supportive care, and correction of precipitating factors are crucial to improve outcomes. A multidisciplinary approach is needed. Effective management requires coordination between endocrinologists, intensivists, and other specialists. Long-term follow-up to ensure compliance with thyroid hormone replacement therapy and regular monitoring of thyroid function tests is essential to prevent recurrence. These are the reference resources. Thank you for watching. Please like, share, and subscribe. Thank you. Have a great day.